pleasure to introduce Nancy Jaffe, who will be presenting on current state of evidence for nutrition interventions. So Nancy is the lead dietitian for the UCLA Digestive Diseases Division. Nancy was recruited in 2012 to help develop a comprehensive GI nutrition program to enhance care for patients with specific nutritional issues and to provide ongoing nutritional education to UCLA GI fellows, gastroenterologists, and other healthcare professionals. The GI nutrition program is now an integral part of the division's integrative digestive health and wellness program. In addition to her lead role at UCLA, Nancy continues her clinical nutrition practice, counseling patients on diagnoses such as IBS, IBD, celiac disease, short bowel syndrome, and idiopathic or functional bowel disorders. And she shares her expertise on nutrition and digestive disorders by speaking at national conferences. Her current research includes the Mediterranean diet's effect on the gut microbiome in IBS with Lin Chang. Nancy is also researching different types of diets and their potential effects on remission and flare states in IBD. Nancy also spearheaded an effort to formalize a GI-specific dietitian group housed jointly under the AGA and the Academy, which became official in 2020 and continues to grow. And with that, I'll turn it over to you, Nancy.
Thank you so much, Jocelyn and Megan. I am really honored to be here and talk about small intestinal bacterial overgrowth with all of you, and a special thank you to Fodzyme, Shar, and Modify Health for inviting me and making this all possible. So I want to actually just let you all know I'm at the tail end of COVID, so if you hear me coughing, I apologize, but I promise we're going to get through this together. I'm excited to share this information with you. So to start, I want to make sure that we all have kind of basic understanding of SIBO. I know this is mainly a provider lecture, but just to make sure that we're all on the same page around the basics before we do the deep dive into the nutrition interventions with SIBO. So let's start with the definition. So the SIBO definition as it stands today is a clinical syndrome of GI symptoms caused by the presence of excessive numbers of bacteria within the small bowel based on aspirate and culture. And you can see the aspirate colony forming unit measurements listed there. But I also want to point out that the current definition of SIBO really focuses on the quantity of bacteria. And a lot of people are thinking the definition needs to change. And what I think is going to happen probably in the next 5 years is we're going to see a definition that includes a lot more, including things like intestinal dysbiosis, and actually looking at which organisms are creating SIBO, because that's where the research is really headed for us. Also looking at intestinal dysmotility, because we know that stasis or lack of movement is a key component in a lot of SIBO cases. Also the idea of translocation, right? Migration of bacteria from one location to another, as well as things like direct injury, changes in functionality and sensation in the gut, even gut immune changes, as well as permeability, which we see as part of SIBO, and lack of brush border enzymes, not to mention all of the different symptoms that can happen, right? So I think that's something exciting to watch out for in the next 5 years, is that change in definition. And you'll notice that I list that we have 2 types of SIBO, and I'm sure a lot of you in the crowd are going, no, there's 3 types. So the reason I put that there's 2 is we technically have hydrogen predominant SIBO and we have hydrogen sulfide predominant SIBO. Methane predominant SIBO in 2022 actually became intestinal methanogen overgrowth, or IMO. And the reason for this was we started to realize that it's pretty different than the hydrogen and hydrogen sulfide forms of SIBO. First of all, SIBO is small intestine, and this is happening not just in the small intestine, but actually mainly in the colon. And it's not actually a bacteria, it's a methanogen, it's a archaea that's actually producing these issues. So they changed the name of it. So you're gonna hear me use SIBO when I'm talking about hydrogen predominant SIBO, hydrogen sulfide predominant SIBO, and IMO when I'm talking about what used to be called methane predominant SIBO. And we will go into that a little bit deeper later in the lecture. So I'm a big fan of putting lots of snippets from articles on my slides. You will all get copies of these slides later. You're welcome to take screenshots, use these slides. That's the whole point, is that hopefully this will help you in clinical practice. But One of the things I wanted to point out is that we don't really know what the prevalence of SIBO is. We, have data like the ones here that show up to 20% of healthy controls based on breath testing may have SIBO. And we're going to talk about some of the issues with breath testing in just a few slides. And you'll also see that it's higher in some of these specific conditions, which actually can be considered risk factors for getting SIBO, right? But you'll see that the percentages are quite broad. They can be 9 to 67% of the celiac disease population. So it really shows us that we have a lot more to learn when it comes to SIBO. And that's going to be probably a theme as we go through all of these slides, that we really have a lot that we need to learn about SIBO. This is another slide that I hope will be helpful later on that shows some more of the risk factors, not just stratified by disease condition, but by structural abnormalities such as bowel resections, motility disorders, including neurodegenerative conditions like Parkinson's, and biochemical disturbances such as low stomach acid. So hopefully this helps you in your practice when you're thinking about the patient's symptoms, as well as do they have any of these risk factors that might put them at higher likelihood of getting SIBO in the future. We also have some protective mechanisms that, of course, if those protective mechanisms are damaged, which they can be by things in the slide previously seen, it's trouble to protect us against SIBO. But when we have these mechanisms, things like secretions from the stomach, the pancreas, and the biliary system, our own innate gut immunity, the migrating motor complex, or MMC, which we'll talk about a little bit later, and the ileocecal valve, that one-way valve that protects against translocation, these can really help keep us from getting SIBO, which is great. And I'm not going to go into detail on this slide, but again, you'll get these slides at the end, or feel free to take a picture. This was actually from Andrea Shin's lecture at DDW 2024, and she gave me permission to show this slide. I thought it was a really nice way of showing some of the pathophysiological and symptom effects of SIBO in the body. As providers, these are probably not surprising to you at all, but I think it's kind of a nice way of categorizing them and putting them into context as we're moving through the SIBO lecture and into really, the nutrition part of it and all of how can we help our patients with these symptoms. All right, so again, I'm a dietitian. I'm not a doctor, so I'm only going to touch briefly on the diagnosing and the medical interventions for SIBO. And again, this is really more just so that we have common language and we're creating context for this lecture. But right now, current SIBO testing methods include jejunal and duodenal aspirate taken endoscopically, as well as breath testing. But I did want to point out that there are some other possible diagnostic testing that's coming our way. Some of you maybe have already seen the portable and at-home breathing devices. They're already on the market. There's a couple of them out there. And these are, there's starting to be data collection showing that these could potentially be useful for helping us to diagnose more accurately SIBO. I think as a provider, I'm both excited and a little bit anxious about some of these devices. I find that there could be great uses for them. For instance, they will be able to check for FODMAP sugars, meaning that we might even be able to check our patients for fructose intolerance or fructan intolerance using inulin intolerance before we ever consider a diet option. But I've also seen patients become very obsessive with these portable devices. And we're going to talk in just a second about how breath testing is not very sensitive or specific. So patients can be constantly testing positive, but not having symptoms, and then they're panicking and they're worrying. So I think that we've got a lot of work to do to figure out how these portable and at-home devices might become part of practice in the future. And what I'm really excited about is these gas capturing and sensing capsules. So these have been in the works for a long time now. I remember talking with CK Yao in Australia about when she was working on this project and how these tools may actually help us to really understand which gases and what amounts are trapped in the GI tract, especially hydrogen sulfide gas, which is a very volatile gas. It's very hard to capture. There's only one test on the market right now that's really able to do it. And we're not even sure how well it's doing it. And so I think this will really change the game when it comes to testing in SIBO in the future. But let's really right now focus on the two main testing methods that we do have. So let's start with aspirate and culture, which right now testing this way is considered the gold standard. But of course, there's pros and cons to this, right? The pros include things like it can be done at the time of the endoscopy. So if the patient is already going in for a celiac test, right? They're getting, they're looking to see if there's any celiac disease, if there's gastritis, if there's peptic ulcer disease, eosinophilic esophagitis. If they're already looking for other things, great, aspirate can be taken at that time. It's also a direct method for assessing SIBO, right? As opposed to breath testing, which is considered an indirect method. And it can allow for identification in the future of specific organisms, which I think is really exciting when we think about the fact that, as I mentioned, the definition of SIBO is probably going to be changing in part because we're starting to figure out which bacteria are the culprits. So we're learning that IMO has specific bacteria that overgrow and create this, or not bacteria, archaea, excuse me, that overgrow and create this issue. And so being able to do an aspirate and check for those organisms could be really useful. But there's a lot of cons, right? It's expensive, it's invasive, it's a procedure, it's time consuming. There's a lot of risk of contamination when we're getting aspirates. Culturing is not always easy for the doctor to do, and we may miss if there's distal disease. So given all of this, plus the fact that there's actually lack of validation, which I think is the best part of this, that our gold standard isn't even validated for SIBO. But technically it's not routinely done, and really breath testing has become the common way that we check. So I just wanted to put up the ACG guidelines for SIBO that came out in 2020 and their thoughts around breath testing to kind of set up the scenario for us around what breath testing has to offer and some of its limitations. What's recommended at this time, and it's a conditional recommendation, is that in symptomatic IBS patients, symptomatic patients with suspected motility disorders, those who previously had a luminal abdominal surgery and are symptomatic, and those with constipation who are symptomatic, all could be candidates for breath testing. But one thing you'll notice is not only is it a conditional recommendation, but all of them have very low level of evidence. So the answer is we really don't even know who we should be checking for SIBO, which is why hopefully those slides I gave earlier about risk factors and protective measures can help us to understand who might be at risk for SIBO so that we're hopefully not testing people when we don't need to be. So with that being said, breath testing has its pros and its cons. For those of you who are not super familiar with the breath testing process, basically there's the patient comes in, they do a baseline exhaled breath test, and then they drink either a 10-gram lactulose solution, or generally speaking, it's a 75-gram glucose solution. I put 50 because those were the old guidelines. And then every 15 minutes, they exhale breath, and it's measured for the different types of gases. And you notice I only have hydrogen and methane on here. So H2 is hydrogen, CH4 is methane. The reason for that is the guidelines on hydrogen sulfide is still being determined. We think it's probably going to be greater than 3 parts per million, but we're still waiting on evidence for that one. And you can see a positive breath test at this time is a hydrogen gas of above 20 parts per million at 90 minutes. With IMO, it is, or methane, it's above 10 parts per million. According to the old guidelines, it was 90 minutes. We sometimes say at any time during the test if this happens. And right now, the North American consensus recommends using a lactulose breath test. Again, these are guidelines that came out really quite a few years ago. So we're still looking to see if that's going to be the case. I think a lot of people feel strongly one way or the other, but I think what's important is we note the sensitivity and specificity of these tests. So just to remind ourselves, because I know I forget all the time, sensitivity is a test's ability to test positive for people who are truly positive, right? So it's finding those who actually have the condition and not making false negative results. Whereas specificity is the ability to rule out people who don't have the condition and label them as being negative for the condition, right? So what you'll notice is that neither is highly sensitive, slightly better specificity. So we tend to have a lot of false positive breath tests, okay? And you can even see my little caveat note that says recent studies performing glucose or lactose breath testing and scintigraphy found that 65 to 85% of positive breath tests were falsely positive for SIBO. Okay, so we get a lot of false positives here. So I think it's important that we put that in context when we're looking at these breath tests, and especially if our patients are coming in and they're testing positive, testing positive, testing positive, but their symptoms are getting better. I know for me as a clinician, I don't care as much about what the breath test says if the patient is feeling better. But that, of course, is clinical discretion, right? I did just want to put this on the screen. I'm not going to go into it, but these are some of the protocols your patient might be asked to do, before the test and on the day of the test. And again, I'm not a doctor. It's not my job to read and diagnose patients, but I think it's important that we're familiar with what these tests look like. So I just wanted to give you an example of a positive hydrogen breath test where you can see that the increase in hydrogen above 20 parts per million happens around the 30-40 minute mark. So it's within that 90-minute window. For a methane positive breath test, you can see the increase in methane above 10 parts per million around the 30-minute mark. And then I did want to show you a potential hydrogen sulfide breath test. Again, right now, we're thinking the cutoff is at and above 3 parts per million. That's still being debated. Not too long ago, it was 5 parts per million, and they lowered it. Just pointing out that for a long time, at least, this was something I remember I was taught a long time ago, that if you have like a flat line, that means hydrogen sulfide. It doesn't, okay? So really, you have to be measuring the gas, and you also have to be measuring the gas alongside measuring a hydrogen gas. Otherwise, the test is not considered valid. All right, and then just really quick, again, not a doctor, I don't prescribe medications, but I think it's important that we're aware of the types of medical interventions that our patients might be given by their doctor. So for our non-absorbable antibiotic, rifaximin, Xifaxan, the pooled eradication rate is 70% when patients do 550 milligrams TID, usually for 14 days. With other types of more systemic antibiotics, the pooled response rate, according to the research, you can see it's all over the chart, but it appears to be around 51% in SIBO cases. But I want to make note that both for the non-absorbable antibiotics and the systemic antibiotics, the research is pretty poor. So you can see, again, caveats at the bottom. Most of the studies are small. Methodology is flawed. No gold standard for diagnosing. So I think what we're really coming to in the end of this, before we really dive into the meat of our lecture, which is all about nutrition, is that there's a lot we don't know. And because there's a lot we don't know, I think whenever we talk about SIBO, there has to be a level of humility and understanding that we're all in this together trying to figure it out. And so with that being said, I want to give a little bit of context to the nutrition section of this lecture. So I had the really great honor of speaking at Food the Main Course Nutrition Conference in Michigan less than a year ago on this same topic. And it was a 20-minute lecture that I got to give along with Bill Che, and it was fantastic. And as I was preparing for that lecture, I started to realize how poor the evidence was for nutrition interventions. And it really made me want to understand what my fellow expert dietitians in the field were doing. So the way that I went about this to understand their knowledge base, what evidence they used, how they were going about working with their patients, was I decided that I was going to send out an informal survey to 55 dietitians. And I did this in May after I went to DDW 2023 because I was so excited. I thought, great, I'll learn all the new evidence about SIBO while I'm at DDW last year, and there were literally 0 sessions on it. This year was better. There were 4, but there were none when I was preparing the year prior for a lecture. So I decided that I was going to reach out to recognized experts in the field and ask 26 specific questions about diet, supplements, the evidence they're working with, and their practices. And I got 62% response rate. And I really appreciate the data that I learned and the information I got. And so what I'm going to do is there's going to be multiple sections of this nutrition part of the lecture. And every section is going to start with the informal dietitian survey, again, building context. And so to build context for the entire nutrition section we're about to do, I wanted to show you question 10, which is, do you believe there is standardized evidence-based nutrition advice at this time for working with SIBO patients? And you can see overwhelmingly the answer was no. So that means, again, when we're talking about this stuff, keep in mind, I'm going to give the best evidence I can that I'm able to find, limited as it may be. We're going to discuss how people are practicing. And then hopefully we together, in the spirit of collaboration and interest in learning, can figure out best approaches on how we can work with our patients and be an advocate for them. And just like I'm going to be doing this at the beginning of each of the nutrition sections, I'm going to end each nutrition session with either the ACG or the AGA guidelines for small intestinal bacterial overgrowth as they relate to diet and nutrition, right? As they relate to what we just discussed. So here's our first section. So our first section is on the evidence around diet approaches, right? So I went to our dietitians and asked, do you recommend specific dietary interventions when working with SIBO? And you can see it was split. 40% said sometimes, 44% said yes. Not surprising, these were all dietitians. We work with food. This is what we do for a living, and supplements. So I wanted to understand, well, what diet specifically are being used, right? And you can see that overwhelmingly it was the low FODMAP diet and the low fermentation diet was second. So I'm going to focus on those two diets during this section. So again, I'm assuming everyone knows what the low FODMAP diet is, but in case there's any newbies in the crowd, or if anyone listening to this is new to the low FODMAP diet, I want to make sure I just quickly make a note that the low FODMAP diet was created in 1999, the first published study showing benefits to irritable bowel syndrome patients was in 2006. So we've got several decades of research now showing that when patients work with a dietitian and they remove these 5 underlying sugars that you can see on the screen, we get about a 75% reduction in things like abdominal pain, gas and bloating, possibly even stool frequency. So it's really considered a first-line intervention for IBS, diarrhea predominant, and mixed predominant patients. And I just wanted to share that because I think it's important that we think about how FODMAP is used in IBS to help understand the theory for using the low FODMAP diet in SIBO. So as we mentioned, there's evidence to show it can reduce some of the hallmark symptoms that we see both in our IBS cases and in our SIBO cases, gas, bloating, and abdominal pain, right? We also know that some of the high FODMAP foods are prebiotics, and they do have an effect on the gut microbiome. And remember that part of SIBO is intestinal dysbiosis. And again, this is most likely going to become part of the definition in the next 5 to 10 years. So according to the Pimentel lab, which I want to stop for a second, most of you probably know who Mark Pimentel is, but he's a doctor here in Los Angeles at Cedars-Sinai Medical Center. He opened up a lab called the Pimentel Lab, and he's really at the forefront of SIBO research. SIBO has been around for a long time, but he really made it mainstream, brought it to the public, and is really advancing our knowledge and research on it. So you're going to hear me allude to him throughout this lecture. So according to the Pimentel lab, carbohydrate digestion with SIBO is much higher than in healthy controls. And what's meant by that is since there is translocation of colonic bacteria into the small bowel, they have access to carbohydrates they wouldn't normally have access to. And so fermentation increases, right? So we know with the low FODMAP diet, part of why it seems to be successful is we're reducing fermentable carbohydrates, right? So that's one of the thoughts of why low FODMAP diet could help in SIBO. Also, according to the Pimentel lab, 60% of IBSD cases are SIBO. Now, I'm going to say this is a controversial thing to say. The facility I come from, UCLA, chooses not to believe that. But according to the Pimentel lab, 60% of IBSD cases are SIBO. And if FODMAP diet is a first-line treatment for IBS, then it would make sense that we would use it to help with SIBO. So that's just some of the rationale behind it. But let's see what evidence we've got. So I've kind of already given it away, but there is no evidence, right? So unfortunately at this time, no one has evaluated the effect of the low FODMAP diet directly for treating and managing SIBO. And I say directly for treating and managing because I'm going to show you a study that came out just a few months ago, actually. It came out in April, where they used the low FODMAP diet as baseline, but they were actually testing herbal therapies for patients. So we still don't have a article or a research study where they were looking at the low FODMAP diet as the primary outcome. There were 12 studies, though, that did talk about the potential connection between changes in the gut microbiome and low FODMAP diet. Again, SIBO, if we're thinking of SIBO as possibly a form of intestinal dysbiosis, then that does mean something, right? If we're seeing changes in the microbiome because of a low FODMAP diet. Unfortunately, when we look at these 12 studies, they're contradictory. Some studies will show an increase in one species, a decrease in another, and then another study may contradict that. So we're still figuring out what that could mean in the context of SIBO and using a low FODMAP diet. One interesting piece of evidence that we did find, though, is the low FODMAP diet can increase hydrogen sulfide producing species. Granted, we don't know if that means that being on a low FODMAP diet puts patients at higher risk of having hydrogen sulfide SIBO. That connection has not been made. But it is an interesting piece of evidence, and I hope someone will look into it so that we have better ways of working with patients who are diagnosed with hydrogen sulfide producing or hydrogen sulfide SIBO. There also were 2 studies that looked at exhaled gases, so the breath testing along with a low FODMAP diet. And they did find that there was a slight to maybe a significant decrease. So again, one study said slight, one said significant decrease in hydrogen production. But again, we don't know if that's because of the low FODMAP diet changing motility, right? Or whether it actually did change SIBO status. We don't really know, because this is another thing with our breath test is sometimes we will get false positives because a patient's motility is elevated. And if they've got an escalated motility, that can give us that false positive of the breath. So the answer is we're not sure, right, with the low FODMAP diet at this point. So we have no evidence for using it to treat SIBO, but it certainly could be used to improve symptoms related to SIBO and IBS. So that's kind of where we're at with the low FODMAP diet. What about the low fermentation diet? So the low fermentation diet was created in the early 2000s by the Pimentel lab. And all you see in italics is actually taken directly from Dr. Pimentel's book, The Microbiome Connection, which just came out in 2022. So according to the book, the premise of the low fermentation diet is one, to look at current scientific knowledge around the gut microbiome. 2, the interaction between that gut microbiome and food that's eaten. 3, pathophysiology of IBS and SIBO, as well as 4, restricting high carbohydrate foods and foods that cannot be digested well. And there's 2 essential rules to the low fermentation diet. One is restricting those high levels of carbohydrates or ingredients that the human microbiome is not able, or I'm sorry, that humans can't digest and the human bacteria can. And also to space meals 4 to 5 hours apart. So for those of you who haven't seen the low fermentation diet before, I wanted to pull out, again, this is from the book, what foods are included and what foods are excluded. But I also thought it was important to look at where it aligns and where it misaligns with the low FODMAP diet. So what I tried to do was in red, put the things that are not allowed on a FODMAP diet or are allowed on a FODMAP diet if they're in the wrong category, right? So leafy greens are allowed on low FODMAP diet, but they're excluded in a low fermentation diet, and garlic and onion is not allowed in a low FODMAP diet, but it's included in the low fermentation diet, etc. So what you'll notice is it's not a very nuanced diet, right? It's very black and white. White bread is good, whole grain bread is not good. And we know from working with the low FODMAP diet that when we're looking at something, for instance, like a bread, we're not just looking at whether it's white or whole grain. We're looking at, well, what grains are in it, what portion size is, what's the preparation method. All of those can play a role into whether or not the food would be encouraged or discouraged as part of the diet. I also wanted to give a couple quotes from Mark Pimentel, both from his book as well as interviews that I've listened to with him. He says, we recommend carbs that humans easily absorb and digest, like white bread of all things. And when we advise less fiber in the diet, it doesn't matter whether it's soluble or insoluble, less fiber means less gas production. Okay, so let's remind ourselves about fiber. For any of you who have heard me lecture before, you know that I love talking about fiber. It's one of my favorite topics. I think it's fascinating and confusing and wonderful. And fiber, when we think about it, solubility is often the first thing we think about, but fiber is so much more than that. It's also viscosity, it's the effects on the gut microbiome and metabolite production, pH changes in the lumen and how that affects stool production, and especially in the context of this lecture, fermentability, right? So key differences between fermentable fibers and FODMAPs is the rate at which they're fermented, right? And we know that some fibers are tagged as being readily fermentable and some are tagged as being minimally fermentable, right? And fiber is composed of long chains of sugars, whereas FODMAPs are short chains, right? And so as a result of that, even those fibers that are listed as readily fermentable, they are still going to ferment at a slower rate and produce less gas in a more controlled and steady manner than FODMAPs would. So to say that all fiber creates gas and symptoms is simply not a true statement. So I think it's important that we kind of check some of the assumptions that, oops, I just lost my slides, that the low fermentation diet is making, right? Which is this idea that all fibers are fermentable. Again, we just disproved that theory. Also, that white is better. So we also know that white refined flours could be very high FODMAP, right? Being white does not automatically mean better. Also, that they make note in the book that vegetables that are quote unquote fruits or roots are GI friendly. And we know again that this does not change the way the fiber is connected. You could still have short chain carbohydrates as culprits, and that it just, garlic and onion are some of the biggest bloaters for a lot of our patients. And so saying this is just simply not true. Beyond that, we don't have any evidence to support it, right? I think that's the most important part of this. But I will say, I have patients who come into my office on this diet and they have found it helpful. So of course, as a provider, if someone comes in on this diet, I'm not going to say to them, well, that's silly. You shouldn't be on that. There's no evidence for it, right? We want to start with the patient where they're at, of course. So instead, I might go, great, I'm so glad you're feeling better. What percentage improvement are you noticing in the different symptoms? How long have you been on the diet? And are you open to now us moving you into a less restricted model? And I'll often use the low FODMAP diet as a way to kind of usher them out of the low fermentation diet. And then we can actually go through the different phases and figure out, well, what was working for them and what wasn't working for them. So in the end, what do our guidelines have to say about diet? What they basically say is that there's no evidence-based diet for treating SIBO at this time, which we're aware of. They do note that using things like a low FODMAP diet may improve symptoms by reducing fermentable carbohydrates. All right, so let's move into our next section, which is all about supplements. So again, I went to our dietitians and I asked, do you recommend any specific supplements for patients with SIBO? And you can see that we have an overwhelming amount of sometimes, and then a split of 18% for both the yes and the no group. So of course, I wanted to understand what supplements were being recommended. And what we found is the big ones that were being recommended were fiber and peppermint at 53% each. And then we also had probiotics and Atrantil at 12% and 19%. So those are the ones I'm going to focus on. So let's start our conversation by looking at fiber at 53%. So I wanted to dig a little deeper into the fiber question, and I wanted to know, well, what fiber do you recommend if you recommend a fiber? So overwhelmingly, the answer was psyllium at 62%. And I wanted to understand, well, why psyllium? Why is that being recommended? And what our dietitian said is that it was really to help symptoms, right? It was to help with bowel form and motility. And then the next high fiber one that was used was PHGG, or partially hydrolyzed guar gum, at 44%. And when I asked why that was being used, that they actually said for treatment purposes to eradicate SIBO. But I also want to point out that 28%, no, you don't use fiber, right? So that kind of goes along with that low fermentation concept of reducing fiber in the diet. So let's look at PHGG, since it was used because of eradication purposes. So PHGG is partially hydrolyzed guar gum. It's a polysaccharide. It's used as a thickening and a stabilizing agent in a lot of our food. And when it's partially hydrolyzed, it actually allows for water absorption, which means that it can actually help with bowel motility. It can help with constipation, according to the research. So in terms of it treating SIBO, there was one study that was done in 2010 on 77 patients that were diagnosed with hydrogen predominant SIBO using a 50-gram glucose breath test. And they were then randomized into a rifaximin group at 1,200 milligrams per day, or a rifaximin group at 1,200 milligrams per day plus PHGG 5 grams per day. And they did this for 10 days. And they also gave them questionnaires and breath testing at baseline and 1 month after completion. So the hypothesis was antibiotics only act on intestinal bacteria, but to solve the SIBO issue, we need to deal with what is causing it. And so they felt like aiding motility would help. So that was the goal of using the PHGG, was really to aid motility. So what did they find? They found that eradication rates in both groups were good, but you can see that it was greater in the PHGG group, although it did not meet statistical significance. They also looked at eradication rates clinical improvement in the people who their SIBO had been eradicated. And this is what I love seeing the clinical improvement over just the breath test improvement, right? So we see that we had pretty good breath test improvement in both groups, but we have to remember that this was one study. They weren't using the standard dose of antibiotic treatment. So remember, we had said it was 550 milligrams 3 times a day for 10 to 14 days. This was a dose of 1,200 milligrams. They didn't get to that 1,650 milligram dose. It was not a standard length for antibiotic treatment. Really, it kind of was. 10 to 14 we see used pretty frequently nowadays. But they didn't test until after a month, right? And they didn't follow up to see if recurrence rates happened, right? So I think we just have to keep in mind that we don't have a ton of evidence on that. But it maybe helped to improve symptoms over antibiotics alone. And maybe if it's helping with motility, and motility is an underlying driver of the SIBO, certainly it's a rational thing that we could be using clinically with our patients. So what do our guidelines have to say about fiber specifically? Basically, they recommend reducing fermentable fibers might help, but they don't say that they need to be on a low fiber or low fermentation diet or go on fiber supplements at this time. But as we saw, PHGG might be helpful. I just hope that more research will come out on it in the future. All right, what about probiotics? So I asked about probiotic use, and you can see that actually our dietitians actively avoid using probiotics. So about 88% avoid using probiotics. But for those that do use probiotics, overwhelmingly, they were using S. boulardii at 21%. But, you know, there were a smattering of other things that came up in here. So let's take a look at what the research on probiotics in SIBO has to say. So basically, there was one comprehensive meta-analysis and systematic review that explored probiotics in SIBO. It included 14 full-text articles, 8 abstracts. And basically, it showed probiotics had an insignificant trend towards lower incidence, meaning that it doesn't seem like taking a probiotic helps with recurrence rates. What they did feel like they found was that there was a higher what they call decontamination rate. So that means on breath tests, the breath test got better, right? So the eradication rates seem to be good. So according to these authors, the present findings indicated that probiotic supplementations could effectively decontaminate SIBO, decrease hydrogen concentrations, and relieve abdominal pain, but were ineffective at preventing SIBO. Now, I want to point out, when this article came out, it got a lot of press and a lot of people were really angry about it. They claimed that there were too many limitations for the author to be able to make this claim. One, the papers that were used were small studies and of poor quality, but unfortunately, we don't really have significantly better options. So this was what was available. But beyond that, there were not a continuous use of the same types of probiotics, right? So it was polyprobiotics, multi-strain. They didn't give the strain. So we don't even know what this means. It's kind of a catch-all probiotic statement, but we don't have specific recommendations. So that made me really curious about what the dietitians were using, which is S. boulardii. And I have to say, dietitians, you guys are an amazing group. So smart. So there is actually quite a lot of research on this very specific type of S. boulardii, CNCMI745. So as a reminder, when we're looking at probiotics and evidence, we don't want to just look at genus, which would be the S in this case, the Saccharomyces, or we don't want to just look at the species, boulardii. We want the strain, which is usually a collection of numbers and letters, which tells us that something has been researched, right? So what you'll see is that we've got evidence here in hydrogen-predominant scleroderma cases. We've got it in hydrogen-predominant SIBO cases who were also suggested to reduce fermentable carbohydrates. In both the 2023 studies, they were not told to go on a low FODMAP or low fermentation. It was just kind of a general recommendation to reduce some of these carbohydrates. And what I love is not only did they see differences in terms of the breath test, but again, for me, the more important part, they saw improved symptoms, less diarrhea, patients felt better. And there was a study that came out this year on decompensated cirrhosis hydrogen predominant SIBO cases. And not only did taking S. boulardii, this specific strain, help to reduce SIBO by 80%, but it also helped to reduce ascites and hepatic encephalopathy. Now, granted, these are sick patients. Probiotics are not indicated for every person. They did have a few adverse events. So this is something that you would definitely want to talk with the team about before you would recommend a probiotic. But I thought that this was really fascinating. And it really tells us that there needs to be more research, right? So what does our guideline tell us about probiotics? Basically, it says there's no evidence at this time for either recommending or discouraging probiotic use in our SIBO patients. So if our patients are already on a probiotic and they feel like it's helpful, we don't necessarily have to take them off it, nor do we need to tell them they should be on one. I am excited about the prospects of this very specific form of S. boulardii and see how it might be utilized in the future. All right, so more supplements. So some of you may have heard about this herbal supplement called Atrantil that's on the market. It's a combination of 3 botanicals that are touted to have all sorts of different effects, which I'm not going to read out, but you'll have the slides that you can review later. So what does the research show us? So we originally had 2 studies that came out because this product was released right around when these studies were done that were on IBS-C patients, not SIBO patients. And they basically showed that when patients who had IBS constipation dominant, they had success rates in bloating, constipation, and abdominal discomfort reduction by 80 to 88%. Okay, a couple things I want to make note of. First of all, not SIBO, but this is the evidence we have. And second of all, you'll notice that the author is the same author and that both of these were done at the single site. So this is the inventor of, Dr. Brown is the inventor of Atrantil. He did this research at his office. That doesn't mean that it's not interesting research. It doesn't mean that it's not useful, but I always get a little nervous if there isn't some outside source that's also digging into this to let me know if the results found are accurate. So luckily we had a clinical trial that happened last year. Actually, yeah, it was last year on IMO, where they were looking at Atrantil as a treatment for intestinal methanogen overgrowth. This was done at Northwestern. They had 39 IMO positive patients. All were put on a 4-week supply of 2 capsules TID of Atrantil. And what they found is that symptoms did significantly improve. Okay, so abdominal pain, gas, and bloating got a lot better. Constipation got better, but not meeting statistical significance. But this is what I love. The response rate was good, 56%, but it did not change their SIBO diagnosis. So it didn't actually help the IMO as much as it helped probably their underlying condition, which could be IBS, could be something else, right? And we see this as kind of a trend, but I'll get into that in a second. So with Atrantil, again, no evidence basis for recommending it. It's not part of our guidelines at this time, but it might be helpful for treating or working with some of our IBS-C patients, could help, especially with pain and bloating. What about other types of herbal remedies that are out there? So it's very, very frequent that I'll have patients come to my office and they'll say, I got diagnosed with SIBO. I was told to go on antibiotics. I really don't want to go on antibiotics. My friend told me about this herbal remedy that I could take. I want to do that instead. So if you ever have someone come in and say that to you, I want you to know what study they're probably talking about. So in 2014, 104 patients who had hydrogen predominant SIBO were given either 200 milligrams TID, so just make a mental note, that's only 600 milligrams of rifaximin, or 2 capsules of 2 sets of 2 commercially available herbal preparations. And they did this either the 200 milligram TID rifaximin for 4 weeks, or they did the herbal remedies for 4 weeks, okay? And if the rifaximin patients didn't respond, they could then be, moved into the other group, given the protocol, or they could be given a triple antibiotic therapy for 4 more weeks. So in the end, out of those 104 patients, 37 of them received the herbal therapy. 46% had a negative follow-up breath test compared to 34% in the rifaximin group. And for those who were non-responders of rifaximin, 31% were offered the herbal remedy. Out of that 31%, 57% then went on to have a negative breath test, and 10 non-responders were offered the triple therapy with 6 responding. So what does this all mean, right? I think it's really important we note, first of all, it's one study. Second of all, the evidence is really limited just based on this study. So again, the rifaximin group was put on a non-standardized dose of the antibiotic for a non-standardized length of time, 4 weeks instead of 10 days to 14 days, right? Also, we lack statistical significance that it made a difference. So these percentages are often quoted, but it didn't actually meet statistical significance, and it was never replicated. So one study does not mean that we should be, prescribing these herbal remedies to our patients. I was happy to see that another herbal study did come out. It was on different products this time, but this is from earlier this year. It was on 179 patients who were followed for 3 months. And this time they included not just hydrogen SIBO, but IMO patients, which I thought was great. And basically the hypothesis for this study was that we can't just treat SIBO. We also need to deal with the intestinal dysbiosis and the gut permeability issues to make sure that we're really eradicating the SIBO issue. So the way that these study authors chose to do the study is they did 2 phases. They had phase 1 was cleansing, which basically means eradication. And whether you were in the hydrogen SIBO group, the IMO group, or there was a control group, you were on a low FODMAP diet. Okay. And then the hydrogen SIBO group was on rifaximin, and they were on 600 milligrams for 10 days. So again, not a standardized dose, but then they were automatically put on this specific type of herbal supplement called Aleo caps, which, just so you know, it's basically essential oils of things like oregano, lemon, cinnamon, mint. And I think it was because there had been a study on essential oils being used to treat SIBO in rats. So they were basically trying to see would it work in humans, and then they also paired it with an unknown amount of berberine. In our IMO patients, FODMAP diet, rifaximin, neomycin, they were also, I thought, interestingly, given Espelardi, we don't know what strain, for 10 days, and then they were put on this same Aleo caps plus wormwood. They did not explain why one group got berberine, one group got wormwood. They didn't talk about that, unfortunately, in the study. And then we looked at the phase 2, which is the recovery. So this was looking at dealing with the dysbiosis and the permeability issues. So this is when the groups were either given a probiotic plus L-glutamine and PHGG, or a probiotic just plus L-glutamine, right? And again, can't explain why they chose to do one thing versus another. And in the end, it doesn't matter, because unfortunately, the evidence showed that it did not help, right? So not only did it not make a difference for the controls or for the intervention groups, but the symptoms only got better in the IMO group, which again, I thought was really interesting. It's kind of that Atrantil thing again. Is there something to some of these herbals for constipated patients, which most of our IMO patients are constipated? Again, we don't have evidence to make that leap yet, but I hope that more evidence will be coming down the pipeline so that we can see maybe there is a use for herbal treatments at some point in the future, but probably not quite yet. And just really quick on berberine, there is a study called the Brief SIBO study that is being completed. From what I understand, they just finished recruitment July of last year. So hopefully this study should be coming out and published anytime now. And we'll see if berberine really is a treatment for helping with both getting the breath test to be negative and helping to get symptoms managed. All right, I know I'm running out of time, so I got to go a little bit quicker here. Peppermint is very commonly used in our disorders of the gut-brain interaction. I wanted to point out that there's no studies on it being used as an effective treatment for dealing with SIBO or even managing SIBO symptoms, although there was one case in 2002 that showed an improvement in IBS-like symptoms in a SIBO patient. I think that we have a lot of evidence showing it can be helpful for gas, bloating, and abdominal pain. And so when it comes down to using supplements and herbals with SIBO, our guidelines don't even broach it. We have no evidence, but I think that we can say that there might be a use for things like Atrantil and peppermint. Maybe we'll find a use for berberine in the future. I think that the jury is still out, but we do have some evidence that Atrantil at least might be helpful for reducing bloating, gas, and discomfort in constipated patients. And peppermint, we do have evidence for its use in IBS-like symptoms. All right, so let's finish this up. We're going to go over some gaps in care. So vitamins and minerals, I wanted to find out if our dietitians were checking nutrition-based labs. 9% said always, 52% sometimes, 12% never, and 24% said if I was allowed to, I would, right? If I was allowed to at the place I worked. So I asked what was being checked, and overwhelmingly it was B12, folate, fat-soluble vitamins, and iron. And I just want to point out again how smart dietitians are, because here are our guidelines, and there we go, right? So we know that bacterial consumption can reduce some of our B vitamins, that bacterial synthesis can increase things like folate, and that because of bile acid deconjugation, there can be a change in fat-soluble vitamin absorption and utilization. So what do our guidelines have to say? The recommendation at this time is that certain lab findings might occur with SIBO, especially elevated folate and B12 deficiencies, but they're not necessarily making a recommendation for or against it. But again, we're dietitians, so it's within our scope of practice to, when we believe a patient is showing signs and symptoms or is at high risk, they have, constant SIBO recurrences, they've got a lot of risk factors, it is our discretion to be able to ask for these labs to be run and to replete. All right, what about the recommendation for meal spacing? So I asked dietitians, do you recommend meal spacing as part of your practice? And it was split evenly between yes, no, and sometimes. So I just wanted to really quick explain what the theory is behind meal spacing in SIBO, right? So we've got these things called housekeeping waves, which are also called the cleaning waves, the cleansing waves, the migrating motor complex, the MMC. All of those terms are used. And basically, this begins about 90 minutes after a meal. It usually runs for about 4 hours, but it can keep going until the next meal happens. It consists of 4 different phases, and it can last anywhere from 90 to 230 minutes, as I mentioned. So the recommendation around meal spacing actually came from a paper by Mark Pimentel's lab in 2002 that was inspired by a paper from 1977 that looked at the MMCs and bacterial overgrowth. So it was specifically looking at SIBO. And what Mark Pimentel also did was look at IBS. And with these 2 studies, what was determined is that in patients with IBS with SIBO and in SIBO, some SIBO cases, there are less or no cleansing waves at the 4-hour mark of fasting in this patient group. And what Mark Pimentel even said is that 50% of IBS patients with SIBO had no MMCs, regardless of what time we were talking about. So I'm going to be a little bit flippant here. And I'm just going to point out that we have 1 to 2 studies that are directly looking at the MMCs and SIBO. And what they were showing is a mechanism that already wasn't working and that isn't necessarily going to be changed by spacing the meals. So if it's not working and 50% of these people, it wouldn't matter if you were fasting, do we really need to be telling patients that they need to be meal spacing? I don't know. I think that there's physiological rationale for doing it, right? It's a reasonable thing to offer, but do we need to be really hard about it? The answer could be no. Again, this is clinical discretion, but there really isn't evidence to encourage meal spacing in our SIBO patients. All right, so finally, let's get to hydrogen sulfide and IMO. I wanted to know if recommendations were different in these groups. And most of our dietitians said not really, right? They're doing a lot of the similar stuff. So what do we know about hydrogen sulfide SIBO? We know that there are many bacteria that produce hydrogen sulfide gas, and that what's coming up in the research as probably the most likely culprit organisms for hydrogen sulfide SIBO are the 2 that you see listed here. And that when these 2 are in higher numbers, we see symptoms such as diarrhea, most commonly, pain, and urgency. But there's a lot we don't know. So first of all, we don't know best practices for diagnosing it, right? As I mentioned, there's only 1 company on the market that I'm aware of that has a validated test for all 3 gases. We also know that prior technology was not stable for transporting hydrogen sulfide gas. It's a highly reactive chemical. It's very volatile. It's hard to sense. And it really requires specialized transportation, which is why I'm excited about these gas sensing capsules that are going to be coming. We also don't know what medication treatment to use. So there was a study eons ago, decades ago, on bismuth and rifaximin, or couldn't have been decades ago, so rifaximin. Bismuth specifically was studied in hydrogen sulfide cases, and then they added rifaximin. And it had some benefit, but we really don't have enough that that's what is being recommended. And it's definitely not part of the guidelines. The guidelines don't even mention hydrogen sulfide SIBO at this time. So for diet therapy, I've heard dietitians say things like, let's put them on a low or reduced sulfur diet or avoid low FODMAP diet. Again, we don't really have evidence to substantiate using that at this time. So I would just say, we need to be mindful of scaring our patients about food and possibly creating some disordered eating patterns. So really making recommendations only when it's warranted. And then what about with IMO? So in IMO, it's believed that more than 30% of SIBO cases do have this archaea buildup. That archaea in the small bowel and colon is why it's no longer called SIBO, but IMO. That the main methanogen is this specific guy called M. smithii that is consuming hydrogen, producing methane, and the most common symptom is constipation. There was just a study this past year that showed one of the only hallmark traits that they could point out between IMO and SIBO, besides the constipation as the hallmark symptom, was that we don't see B12 deficiency because M. smithii is really good at synthesizing B12, and so we don't generally see that deficiency in this patient population. But with IMO, I think, it's really a chicken and an egg scenario. We don't really know, are these people chronically constipated? Which I can tell you, most of my IMO patients were chronically constipated before they got the IMO diagnosis. And that's what led to the perfect scenario for this IMO to occur. Or did the IMO create the constipation? We don't really know. We also don't have great medication recommendations at this time. There was only one study that said we should be using neomycin and rifaximin. For a long time, the Pimentel lab was looking at statins, but they failed, and so they're not being used as common practice. So my recommendation around diet at this time is to focus on the symptoms, help resolve the constipation. I've seen that is very effective at helping to keep relapses at bay. So with that, I'm going to end my lecture. I want to start by thanking all of the dietitians who participated in the survey that I did just a little less than a year ago. And I appreciate a lot of the comments that were given, including things like this, which is, being mindful of the recommendations we make because it really does impact our patients. And we want to make sure that the work we're doing is effective and respectful. And that also, I love this quote by whoever wrote this about, that we can feel a little bit crazy when we're talking about SIBO because it's frustrating, right? And so I think, again, we have to always come with that level of humility and understanding that we really don't know a lot when it comes to SIBO, and we're all trying to figure it out together and to make sure that we're using that as common language. So with that, I thank you all. I hope this was helpful. If it was and you want to send comments, please do. If it wasn't and you want to give me advice, you're welcome to do that as well. And I'm happy to take any questions.
Great. So thank you so much, Nancy. That was wonderful. We have a lot of questions. I will get to as many as we can up until 2 o'clock, and then we will be ending it. So the first question is, does Roux-en-Y for bariatric surgery have a higher risk for SIBO? I saw that Roux-en-Y construction on the list of conditions. Unsure if it's the same thing.
The answer is, as far as I understand, the answer is yes.
Okay, thank you. What are your thoughts on the SIBO biphasic diet? I have a client who's been on it for some time and is hesitant to advance the diet despite dietitian recommendations to do so, but I'm concerned about over restriction. She's being treated with Xifaxan and Allicin under the care of a physician.
Yeah, I mean, I think you're right on that we don't have evidence to be using the biphasic diet. I didn't bring that up. For those of you that are not familiar with it, this was, I believe, created by Alison Seibecker, who's up in Oregon, who is a naturopathic doctor. Really interesting woman. If you have a chance to listen to some of her webinars, they're really interesting. And she's the first to admit she's not doing things based on evidence. She will outright say, I'm not doing things based on evidence. I'm doing on what I feel might work well for my patients. So for me, when I have a patient come in and they've especially been following a diet for months, and they're still sitting in my office, they're clearly not getting better. So we'll talk through, well, what do you feel has been helpful about the diet? What has not been helpful? Reminding them that diet is not a cure. It's not a prevention. It's more to help with symptoms. That's why we're using it at this time. So if they're still feeling bad enough that they're showing up in your office, I would want to help investigate that with them. Plus, I would wonder, are they coming in because their breath test keeps saying they're positive, but are they feeling better? And if they are, great, let's start doing a reintroduction phase.
Great. We have a few questions about probiotics, so I'm going to try to summarize them. People asking about using probiotics after a course of antibiotics. What's the evidence for that? And also, can probiotics then cause a relapse of SIBO? So kind of the opposite question.
Yeah, I mean, we don't have evidence that says it causes a relapse. So that's number one. Um, with those non-absorbable probiotics, we don't think, again, I don't think we have great evidence. And if there's anyone in the audience who knows better than me, please shout it out. But I don't think we have evidence that shows those non-absorbable antibiotics cause significant dysbiosis that we then have to like follow it up with a course of a probiotic. When it comes to more of a systemic antibiotic, yeah, that we know is doing some damage. We've got evidence on that. So that might be where I might consider a probiotic. And again, I'm going to use one of the ones that we have really good evidence for things like irritable bowel syndrome, but I don't always feel it's necessary. Sometimes I may instead recommend like low FODMAP prebiotic and probiotic foods. I love to go food first if I can, instead of going straight for the supplement. But no, I don't have, there's no evidence that says it's going to cause a relapse. So I'm not afraid to use probiotics, but do I use them regularly? No.
Great. And last question, I feel like this is a good way to end it. Given that there's limited evidence for many of the interventions, how would a dietitian approach an intervention to try?
Yeah, I think it's a great question. And this is where I think having conversations with fellow dietitians can be really helpful. And then also being transparent with your patients, right? So when I try, something like Atrantil with a patient, I'm very upfront about where the evidence is, but why I think they might be a good candidate. So you have these symptoms. There's 3 studies that show it may be helpful when a patient is constipated, they've got bloating and abdominal pain. We're working on your constipation, you're still having your bloating and abdominal pain. This is a potential thing we could try. Let's give it 2 weeks, 4 weeks, 6 weeks max. And if we're not having benefit, we're going to stop. We also, of course, want to consider what's feasible for the patient. These are expensive. Supplements cost money. There's a real thing such as pill burden, right? Patients get burnt out on taking these supplements. So we also want to just be thinking about those things. Is this a reasonable and responsible option for this individual patient? And I can tell you, I don't use things like Atrantil very often. Rare.
Yeah, very practical advice. So thank you, Nancy. Everyone, you will be receiving your certificate of participation, and Nancy's been kind enough to be willing to share the slides with you all. You will also get a recording of the presentation that will all come from Jocelyn at Pfodzheim. It'll come out sometime probably tomorrow. So be on the lookout for that. Check your spam folders if you don't receive it. And thank you, Nancy, for such a wonderful presentation. And we are so lucky to have you. And thank you for sharing your contact information for everyone.
You bet. Thanks, everyone. I hope this was helpful. And just know that you are amazing out there. Dietitians are rock stars. I'm always in awe of the work that we're doing. So keep doing the good work you're doing. And thank you. Bye, everyone.